Hello, doctors. Thank you so much for joining today's session. And first of all, let me welcome you to First Aid AMC Clinical. I hope that you guys know about us, that we have been helping the international medical graduates, the IMGs, for quite a few times for preparation of their AMC. We take classes on MCQ as well as clinical, and we have a very good number of recommendations. Currently, we are taking classes for our first online batch, which we have taken about 50 students. They are all preparing under us, and all of them are pretty happy with how we took the classes for the last 5 months. And so this is actually the achievement. We hope that once the AMC clinical examination will be open, then our candidates will be the most tough candidates in the exam. All right. So those of you who don't know me, I am Dr. Arshan Ahmed. I'm one of the tutor of First Aid AMC. And First Aid AMC is a Sydney-based registered AMC preparatory course. Usually we used to take classes offline, face-to-face, but nowadays because of the COVID situation, we only take classes online, and probably this will be our preferred method of teaching so far, because AMC clinical is going to be totally online, as I think most of you know. And we are planning to take some sessions on based on totally how AMC will take the exam online, as we know that how AMC can take classes because we have some experience on the online exam as well. Now, important part of any online examination is that in here you don't have that fear when you need to go face to face, and it's easier to appear exam online, trust me. And we will try our best to make sure you guys know how to approach through online face to face, how to make your conversation clear, and how to look better, right? It's everything. When you present yourself online in front of an invigilator, in front of a role player, your surroundings, your appearance, your way of talking, your tone, your voice, everything matters. It's not just only how you know about the cages. Trust me that AMC Clinical looks into a total person. When they pass a candidate, they filter from like 32 candidates, and just three to five candidates pass in one day. So it's really a hard filtering technique they use, and you have to show the best out of those candidates in that particular day. So that's why you need to be a little bit of exceptional, I would say, because I know that this exam is not about competition. It's totally subjective, but it's still the human being is taking your exam, and in human mind subconsciously those things comes up like, well, that candidate did better than this candidate. This comes up like when we took some exam. We also take exam online to prepare our clinical students. When we took students for like 10 students, then in our brain, even if we think no, we will take the exam totally like without thinking other examinee, but still it comes in our mind that yes, that candidate was better than this candidate, so let's pass that examinee. So that's the reason that you need to make sure that you look exceptional, you sound exceptional, and your approach is exceptional, and we can help you with that. And obviously your knowledge about the cages is also very important. Now, today's session is based on psychiatry. Psychiatry is one of the vital part to pass the exam. Previously, when it was face-to-face, like offline physical exam, the most important, I would say, physical examination, because in case of when you appear at the first time candidate, the physical examination could be the hardest thing which you will face in that time. But now if it is online, that physical examination should not cause you that much trouble. So you should prepare also the other things much better way, so that you can easily pass at least 10 out of 50, out of that 16 stations. I guess all of you know that AMC clinical examination is still the same thing will be there. So it will be a 16 station case, 2 pilot, and another 14 will be a scored station. Out of 14, if you pass 10 station, you will pass this exam. And trust me that passing AMC clinical in the first attempt is the one of the wonderful experience you will ever have in your life. And we want to be a part of your success, and we want to make sure that we prepare you in such a way that you pass in the first attempt, because making a candidate passing in their first attempt, that's the most important goal should be there for any preparatory courses. All right, because many courses can pass you in second, third attempt. That doesn't count according to us. When if we can pass one candidate in first attempt, that's one of the best achievement for any course as far as I understand. And we can help you with those sort of things. So I'm just talking because I wanted to make sure that others can join. Those who are in our Facebook group, are you guys able to hear me properly? You can comment in our Facebook group so that we understand that you can hear us properly. Good. So let's start the session. Today's session based on MSc, which is mental status examination. And we will try to cover all the cases that can appear in related to MSc. And MSc is one of the vital thing for your psychiatry preparation. If you understand how to actually pass that station related to MSc, then psychiatry is all done. I would say like at least 70% of psyche questions covered by how to do the MSc, how to take the psychosocial history. So let's start with the psychosocial history and then we will move on to the MSc because both of them are pretty similar. Psychosocial history. In any time, if in the exam they ask you to take a history from a psychiatric patient, they are asking to follow the psychosocial history format. You should always make sure you follow a format, you follow a cluster so that you can easily finish most of the exam cases in a very short duration. And we make short clusters for most of the cases, which is important for your exam. We have a lot of cluster. We will show it to you at the end of the class so that you understand what you are you should do to prepare yourself. Now, psychosocial history. Anytime you want to ask history from a psychiatric patient, always remember psychiatric patients are kind of a special patient. Out of all the students, out of all the role players in the exam, the psyche role player are the special one, and you should treat them as a special one because they will make yourself crazy in the exam. There are role players in the exam who are like like very good actor, and you will feel really stressed in front of them. So that confidence should be there if you want to face those role player. I'm not trying to scare you, but I'm trying to motivate you because these things are important to know. Otherwise, you will not know like what you guys are going to face. So before you face that, it's best to prepare yourself for that. So any psychiatric history, first thing is to make sure that you take a confidentiality. Confidentiality means that psychiatric patient usually don't want to discuss the issues that they are having, right? Because those are some personal things, and people and psychic patient thinks that, if I share this to others, they will think me as crazy. So that's the reason you need to give them that approach that they feel that they can easily share anything that coming in their mind with you. Now, confidentiality approach, there are conventional approach which most of the candidates follow, like they introduce. So they say that, well, this is, well, hi, this is Dr. X, one of the doctor here. It's very nice to meet you. Please let me assure you that whatever we are going to talk today, it's going to be confidential between you and me unless it is harmful for you or others. This is a very conventional pep talk, which most of the candidates usually use. But I would say don't use that, make a little bit more better approach. So we follow, sorry, so we follow an alternative approach, which is more better than that conventional approach. What is that alternative approach? So always during your entry into the exam station, so you guys know all the things, right? Like that, yeah, your exam stations are 16 stations, and each of the stations are 10 minutes, 2 minute outside, 8 minute inside, right? Now in that 2 minute outside, you will remember that, well, I will ask these things to my patient, and these are the differential diagnosis for this case. And you go inside, and the first thing that you do is your examiner will ask you, well, can I check your ID? So examiner will check your ID and then also say that, well, this is your patient John, you can start. Do you have any questions? So you will also thank the examiner, and you go, you sit down in front of the patient and greet yourself. So greet the patient politely. And now if it is an online exam, then these things will not happen. So just formal face-to-face greeting will be there. So say that, hi, this is Dr. Arshan, one of the doctor here. It's very nice to meet you. John, I can see that you are really sad. I'm really sorry for that you are feeling this way. I want you to know that we are here to help you. You can tell me whatever making you really stressed and upset. I understand sometimes we don't want to share things with others. We just want to keep it within ourselves. But sometimes that doesn't help. Please let me help you. I'll be here unless you are ready to talk. And I want you to know that whatever I'm going to discuss with you today is going to be confidential between you and me. So this is a sad person approach, which means that sometimes in psychiatry, depression cases comes up. So in case of depression, you have to lower down your tone so that they understand that you are also feeling the same empathy for the patient. And trust me, the depression patient are really, really slow, and they will cry in front of you. They will waste a lot of time of you. So you don't want to lose a lot of time. So obviously try to make the patient talk in front of you, because depression patients don't talk. They are very slow. They speak very like taking a lot of pauses in between. So you will feel like, oh man, just talk and talk with me. So remember one thing that is very important to make them feel better. So trust, let me ask you, like if you say this conventional approach, will the patient talk with you? Or if you use the alternative approach that I have shown to you, the patient will talk to you earlier. Obviously, I think the second approach is better. So this is the first thing that you should learn before going into any psychosocial history. So try to use the alternative approach in every psychic cases. It doesn't mean that you have to memorize what's written in here. Make your own approach so that it sounds good, it sounds polite, and it sounds that you care for the patient. Most of the candidates who appear first time or second time, they think that this is a simulatory, like the patients or role player all are simulating, right? And they feel like these are not real patient, so they forgot that part, that, well, if this was a real patient, how I would act in front of that patient. So the candidates usually take their most time on finishing the task rather than making a good rapport with the patient. But the same patient, if it was in front of you in your own practitioners, so what you would do, you would try to make the patient feel better. You would make a good rapport. But in the exam, you forgot that, and that's the one of the important thing. Examiner looks into you, and most of the candidates fail just because of that. And they like you finish all the task, all everything is good. You know that you are going to pass that station, and globally they gave you 3 or 2, and you fail the total station. The global score that they give to you, that's based on your approach. And role player also has something to say on that. After every cases, when you finish the station, examiner ask the role player, how do you feel about this candidate? And if the role player somehow say, no, I don't think it's good, he's good, or I don't feel good, you fail that case immediately. All right, so is understand that role player is a vital part to make your dream come true. So make the role player happy. Okay. After that, you the patient usually will start talking. After that, then start your psychosocial history. Your psychosocial history will start with the mood, sleep, appetite, and suicidal ideation. So start with the mood question. So how is your mood these days? Patient can say, I'm feeling very sad, doctor. Then the next question you should ask, anytime you feel really high, so why you are asking that? You are trying to rule out any history of bipolar disorder. Second question should be sleep and appetite. So how is your sleep and appetite? Patient can say, I can't sleep at night, doctor. It's, it's really difficult to sleep. So any patient having sleeping difficulty, we try to ask some questions to find out exactly what's the problem about the sleep. So the question will be, are you having difficulty falling asleep, or are you waking up early in the morning? So if a patient has difficulty falling asleep, that's mainly anxiety disorder. If a patient has problem with early morning awakening, that's probably depression. The next question will be like, do you think your sleep breaks multiple times at night? If yes, then most likely patient can have some nightmare or something like that. Ask directly, do you do you get any nightmares? Any patient having nightmares, you should always think about that diagnosis most likely post-traumatic stress disorder. So if a patient has sleeping difficulty, then you ask that. If a patient doesn't have sleeping problem, don't need to go into the details. So you ask mood question, you ask sleep and appetite question. The next question, suicidal risk. The very important question is suicidal risk. Suicidal risk, always try to ask 1 or 2 questions. So say that, how do you think about your life? Do you think your life is worth living? Have you ever thought, or have you ever thought about harming yourself or others? So do you think your life is worth living? Any passing thoughts of harming yourself or others? If a patient says yes to any of these questions, sometimes patients say that, no, I don't feel like living, I just want to kill myself. That means patient is having active suicidal ideation, which is a very important thing you should find out in the exam. If they say like that, then the next 2 questions you have to ask is, do you have any definite plan to commit suicide? And have you ever tried before? All right. So normally, if you don't have time, then just at least ask 1 or 2 of this A or B question. After that, you have to ask hallucination and delusion question. So say that, John, I'm going to ask you some screening questions that might seem quite silly or strange to you. These are some of the screening questions for every patient. Please try to bear with me. So then the patient will feel better. Otherwise, if you just start asking like hallucination and delusion question, most of the candidate will say, do you think I'm mad, doctor? Why you are asking this question? So To avoid those sort of confrontation, make sure you say that before you ask this hallucination delusion question. So for hallucination question, you just ask in a single line, do you see, feel, or hear things that others don't? In MSc, this is the perception. So perception problem, usually that's what we call hallucination. So for MSc, that's the perception. Or we need to ask, do you see, feel, or hear things that others don't? The next one will be delusion question. Delusion in case of MSc that included in the thought content. Now for your delusion, we have couple of questions to ask. So for delusion, there are delusion of control, there are delusion of reference, there are delusion of guilt, grandiose delusion, there is persecutory delusion, there is thought withdrawal, thought insertion, thought broadcasting, thought block. So a lot of questions, but you don't need to ask everything. Depending on what's the case given to you, you will pick the important question. Like, what is deletion of reference? Deletion of reference means that patients think that people are talking about him. So we ask questions. Do you think people are talking about you? That's deletion of reference. Deletion of control. Do you think someone is controlling you? Delusion of guilt. Do you think you are guilty? Delusion of grandiosity. Do you think you have some special power? And then delusion of persecution means, do you think someone is spying on you or trying to harm you? All right. So these are your 5 questions main. And then we have thought insertion, thought withdrawal, thought broadcasting, or thought block. So for that, we ask, do you think someone is trying to insert or withdraw thoughts from your mind? Do you think your thoughts are being broadcasted to TV, newspaper, or any radio? Okay, so that's mainly how you ask those delusion question. Now, we don't have that much time in the exam to ask all these 7, 8 questions for delusion. What you should do, if it's a case of depression, you just need to make sure you ask this one at least. Do you think you are guilty about something? That should help your depression. You don't need to ask these other questions. What if it's a schizophrenia patient? For a schizo patient, you have to ask these questions like reference, control, then also asking about spying. So persecutory delusion, delusion of reference, these are very common in case of schizo patient. Also thought insertion withdrawal are common. If it's a mania case, then very important to ask about delusion of grandiosity. All right. So depending on what is the case, you should always ask the questions related to that. After you have done your delusional questions, then you go for insight, judgment, cognition. These 3 questions. So for insight, you ask, do you think you need some medical help? Patient who is having schizophrenia, they usually has loss of insight, so they will not have any insight. Judgment question is, if there is a fire in this room, what you are going to do, John? Patient with schizo will say, well, I will not do anything. I'll be just here. God will save me. Okay, so they have poor judgment, poor insight. Cognition. For cognition, we try to ask that if a patient is having cognition to time, place, and person. Okay, so time, place, person, cognition is important. So we ask, can you please tell me where are you at the moment? What is the date today? And do you know who I am? So time, place, and person. So 3 questions for 3 of these cognitions. So inside judgment, cognition, you have to ask them. After that, then comes to the heads. Heads is a kind of mnemonic, but we don't need to ask all the mnemonic things in here. We just keep heads for home situation and work situation. So ask the patient, John, can you please tell me how is your home situation? Who do you live with? Do you have any stress at your home? Do you have any stress at your work? That's all we need to ask from the heads. The heads usually goes for a lot of things. So H for home situation, E for education or employment, okay, A for activity, and then D for sometimes you can say diet, S for stress, another S for social support, or sometimes we say sexual interest. So we don't need to ask all those questions. We just ask in from here home situation and work situation. That's all, because we don't have that much time for psyche sessions, psychic stations. So make sure you don't go further than this. Then the next question is SADMA. SADMA is again a mnemonic when we ask for mainly smoking, alcohol, drugs, or sometimes you can keep it as a medication, and also like A for we can keep it as an activity, this sort of things, but not very important in here. We usually for SADMA, we just keep smoking and alcohol and also medication. So for SADMA, you will ask, do you smoke or drink alcohol? Any other recreational drugs? Very important in psychiatry to ask about recreational drugs, because sometimes drug-induced psychosis can come in your exam. And if you don't ask recreational drugs, you can miss it. The next important thing that sometimes patient can say in the exam that, yes, I smoke. If a patient say yes, then the next question will be how many cigarettes a day for how many years. Now, obviously, if it's like for a long time and an increased amount, then you have to say, John, if you please give me the consent, I would like to make an appointment to discuss about the smoking. This is the correct approach. Please don't say anything other than that. Like some candidates say, well, I will make another consultation for you about the smoking. Some says smoking is very bad for your health. I would like to discuss with you later on. Don't say anything like that, because patient knows that smoking is bad. Sometimes they feel judgmental, and AMC clinical, you don't want to sound judgmental anytime. You have to be very careful with your word. If anytime you sound judgmental, it causes trouble. Okay. So in here, normally you will ask about smoking, then you ask about alcohol. In the D, you can keep it for recreational drugs. M, you can keep for are you on any kind of medication, and sometimes you can keep allergy. Yes, so any allergies to any medication. But for psychiatric cases, A is not important. We just ask whatever written in here. We don't go further than that, because usually we don't have that much time. Lastly, finish with past medical history, family history, and try to rule out some organic causes. So any past history of mental illness, any family history of mental illness, and just to rule out common organic causes, that means medical related causes. So ask about any change in your weather preference, that's for hypothyroidism, any recent head injury, any flu-like illness. These are not very important, but just to show the examiner that you are trying to rule out some medical causes. So just to give you a summary, that your psychosocial history will be starting from the confidentiality. That is a key step for your station. If you don't do that, you miss a key step and you go further beyond passing this station. So confidentiality is must. Then start psychosocial history, mood, sleep, and appetite, suicidal risk, hallucination delusion, inside cognition judgment, heads, SADMA, past medical history, family history, organic cause. This is the format you should always remember whenever you are taking any psychosocial history. Clear for everyone? Any question on this? Oh, so regarding smoking, you should say, well, a patient says that, yes, doctor, I smoke. Or patient says, yes, I drink. So some next question should be how much cigarettes in a day for how many years? So if it is like for a good number of years and a increased amount, then say, John, if you please give me the consent, I would like to make another consultation for smoking with you. All right. The main thing is that you can't say anything, but you have to say with your consent. That's the vital part. So you have to say with your consent, I would like to make another consultation for smoking, please. So that gives your psychosocial history. After your psychosocial history, come to the MSc format. Now for your MSc format, your exam in the mental status examination, the question will be like a patient coming to you for recent change in behavior. You have to take the MSc and present MSc to the examiner. This is how this cases comes. In such case, what you have to do for MSc format, always you have to always write this in your paper. When you enter into the room, I'm talking about the previous, like when we used to go to the station and we do the face to face. At that time, when you sit in the chair or in the table, you have to write aseptic J3R in your paper. They provide a pen and a paper. They don't mind if you write anything there. So always in a MSc case, write aseptic J3R like this, just at least ASEP like this, because when you ask questions, they will give you some positive findings, and that positive findings you have to present to the examiner. And if you don't write it, sometimes you will forget it eventually, or sometimes you may miss it even though you have asked it to the patient. So that's the reason you should always write it in the paper. MSc cases comes in a two ways. One, it comes like as a taking a history from the patient, or sometimes they just give a video and you just need to find out that this aseptic J3R from that particular video. We will show the video and we will also do a role play in front of you today to show you that how you should prepare these MSc cases. So for aseptic J3R, what are the component of it? One, A for appearance and behavior, S for speech, E for emotion. Emotion includes mood and affect. Mood is what a patient says when you ask, how is your mood? If I say that I'm feeling so upset, doctor. So so it means that my mood is low or my mood is kind of upset. What is the affect? Affect is what a examiner sees in a patient. So you as a doctor, what do you think about the mood of that particular patient? If you think that, yes, I can see this patient's mood is also low, then you can say, well, affect is congruent with the mood. This is how you have to say if the affect is congruent with the mood or not. After emotion, then perception. Perception is the hallucination, as I said before. Then your thought form. Thought form we will discuss just in a couple of minutes. Thought content is delusion. Then you have insight, cognition, judgment, and lastly 3R. So it's very easy if you remember this mnemonic, aseptic J3R. Now last 3R, one is risk, another is rapport, another is reliability. In the risk, you have to find out if this patient is risky to himself or others. So what you should look for these things, you have to find out if the patient is having any active hallucination, any active delusion, any active suicidal or homicidal thoughts. So if any of these are there, patient is high risk. Then rapport. Rapport means that if during your conversation, if the patient is answering your questions appropriately, and then it means that you are able to make a good rapport with the patient. And what is reliability? Reliability means the history the role player provided to you, is this history reliable or not? This is a particular area most of the candidates get it wrong. Reliability means that always any patient who is a schizophrenic patient, who is a mania patient, their history is never reliable. So you have to always take a collateral history from others, likely like family members, relatives, roommate, neighbors. So you have to take a collateral history for those patients. But depression patient has insight, OCD patient has insight. So in those cases, you can say that history is reliable. Good. So let's move into detail about the MEC format. So when you present MEC to the examiner, you have to follow some things so that you can use that for every MEC cases. Always try to introduce about your patient. There will be an stem given in the exam. Use that stem to start your MSc. Say that, dear examiner, I would like to present the mental status examination of my patient, Mike or John, a 35-year-old patient found by his partner trying to hang himself in the garage. This case was about a veterinarian doctor who tried to hang himself in the garage after a dog or cat died during surgery. All right, so a vet is a very important case. So veterinarian doctor found hanging himself in the garage and he thinks that he killed the cat during the surgery. So this was a depression case. So start like that. So give a brief introduction and then start that appearance and behavior. In appearance and behavior, you look for certain things. Remember, among all the MSc format, among all the aseptic J3R, A is the most important one because they want you to see that what the role player showing you. Because all those role player will give you some clue about the diagnosis. Like a schizo patient will look into the corner of the room and show that they are trying to talk with someone or they are seeing someone. So sometimes OCD patient will have frequent movement of the fingers or hand, like kind of fidgeting. So it shows that they are anxious. Then depression patient will sit in a stooped posture, looking down, not making any eye contact. So these are all clues which you have to look into the appearance and behavior. So you have to say that, well, what are the important things you will comment on appearance and behavior? So first comment about the dress. So if he is dressed appropriate to the weather, well groomed or unkempt, cooperative or not, maintaining eye contact or not, and is there any abnormal body movement or posture? These 5 things you should comment. So well dressed, or like dressed appropriate to the weather or not, well groomed or unkempt, cooperative or not, maintaining eye contact or not. Maintaining eye contact is very, very important because this will be a vital things to say in a depression patient. Abnormal body movement, like I said, stooped posture, like kind of leaning forward and looking downwards, that's your depression patient. Frequent fidgeting of the hand, that is anxiety. Restless, agitated patient is mania. Mania patient will make you crazy, trust me. They usually like do a lot of mess. They run in the room, they try to go outwards. They are really, really hard to settle down in the exam. So you have to be very calm during that time. And then the schizo patient will seem distracted and seems to be responding to some unseen stimuli, which means that you will see the patient is looking uh, into the ceiling or looking into the other part of the room, like showing that he is seeing someone. That means that he is responding to some internal stimuli or unseen stimuli. All right. So this is your appearance and behavior. In appearance behavior, please try to comment on this thing. These are very important. After appearance and behavior, the next thing that you talk about is the speech. How is the speech of the patient? In speech, you comment about rate, volume, and tone of the patient. Normally, if how I am talking to you, it means that my speech is normal in rate, volume, and tone. Depression patient will have a slow monotonous speech, so you have to comment that slow monotonous speech, like to be very hard to hear, and like monotonous means whatever you are asking they are just answering with one single word. Like if they say, if you ask that, do you think you are, do you have any sleeping difficulty? Yes. Do you have any trouble concentrating? Yes. So whatever you say, just answer is yes or no. That is slow monotonous speech. Another speech is rapid pressure, which is a characteristic of mania patient. Mania patient, whenever they will talk, you will see that this is the mania patient. You will understand at that time immediately. So their speech is very rapid and high, loud, and also it seems pressure. So they will talk a lot, and like you will not understand anything what they are saying. So rapid pressured speech. Also, talking in pauses in between, that's depression, and disorganized speech, that is psychosis. All right. So in speech, you comment on if the speech is normal in tone, volume, and rate, or if it is slow monotonous, or if it is rapid pressured. So you have to comment on this thing. After that, go to the emotion. For emotion, like usually you will say, according to the patient, his mood is whatever patient will say when you ask that how is your mood, you have to say that in here. So patient says that his mood is low and the affect I observed is congruent with his mood. Then for the perception, we have hallucination. There is auditory hallucination, visual hallucination, tactile hallucination. So do you see, do you see, feel, or hear things that others don't? So see is visual, hear is auditory, feel is tactile. That will go for perception. After perception, then there is the thought form. So we have thought form and thought content. Don't get confused with these two things, because most of the candidate like usually get confused with which one is the thought form and which is the thought content. Thought form is that in a single word it should be like how you are thinking. Are you thinking like a crazy person, or are you thinking rationally? If your thinking is rational, like if you are answering my questions appropriately, you are not having any loosening of association, I can understand what you are saying, that means your thought form is linear. Even a schizophrenia patient's thought form can be linear. Like most of the exam questions cases, the thought form will be linear because they are answering your questions appropriately. So in that case, the thought form, you will say thought form is linear. Now, what are the other components of thought form you should know? One is loosening of association, which is a schizophrenia patient usually shows. Loosening of association means that whatever patient is saying, there is no connection between each of those sentences. Like, like I will say, I'm asking you, what's your name? And the patient says that, well, my grandfather name is John. My grandmother was very nice. And all right, well, I'll drive to the movie. That book was really nice and interesting. Well, I have to eat my dinner today. So, do you see any association of whatever I am talking about? No, that is called loosening of association. And similarly, tangentiality and circumstantiality are a part of this loosening of association. If a patient answers your questions after going a lot of talking, and at last answer your question, like when I said, what is your name? I'm saying all those things, and lastly, I'm saying, yes, my name is Dr. X. That means it's circumstantiality. If the patient doesn't come back to the original question, just goes and goes and goes, That's tangentiality. Normally, that's not important for your exam. If you can just find out loosening of association, that should be fine. There is another important one, which is flight of ideas. Flight of ideas usually found in mania patient. Mania patient, their speech is rapid pressured. On the top of that, when they talk, they will just move from one topic to another topic frequently. But there will be a little association on whatever they are talking. Like when I say, the patient will say, I ask the patient, what do you think that you have been doing before coming here? Say that, well, I was eating cheese by moon by bus is on the station is near my house. So in each sentence I am talking, it doesn't seem anything, but there is still a little association. That's your flight of ideas. When one sentence, like in many patients, their thought jumps from one topic to another. Okay, so you have to find these out. In mania, most of the mania patients, they will have flight of ideas. So these are the three important things you should look for during thought form as like assessment. After that, come to the thought content. In thought content, that's mainly you look for deletion. So all those deletion question you have to ask here. Sometimes OCD comes in the exam. Also, the obsessional thoughts or compulsive behavior, mainly obsessional thoughts, you should include in the thought content. Okay. After that, then you just say about cognition, insight, and judgment. If a patient is oriented, then say patient is oriented to time, place, and person. And then insight, if the insight intact or poor, is the judgment intact or poor, and lastly finish with 3R. So what is the patient having any risk, and have you been able to maintain a good rapport, and is the history reliable or not? So this is how you have to do the MSc. So the linear thoughts means like if if a patient is answering your questions appropriately, like even a schizo patient, when you ask like, do you think like, are you hearing any voices that no one can hear? Yes, doctor, I can hear the president is trying to talk with me. Okay, so patient is answering your questions. When patient answer questions appropriately, then it's linear thought form. If they just goes like blah blah blah, just don't answer your questions properly, so that mainly having some loosening of association. So in a summary, your aseptic J3R, it should be like this. So if I get a MSc in exam and I have to present the MSc for a sad person, like for a depressed patient, well, how I would say? I would say that, well, dear examiner, I would like to present the mental state examination of my patient, Mike, a 35-year-old patient found by his partner trying to hang himself in the garage. His appearance and behavior was like this. He was dressed appropriate to the weather. He was well groomed and cooperative, but he was not maintaining eye contact throughout the conversation. Throughout the conversation, he was having a stooped posture. His speech was slow and monotonous, but there was no rapid pressured speech or disorganized speech. His emotion was low according to him, and the affect that I have observed was congruent with his mood. And in terms of perception, he did not have any auditory, visual, or tactile hallucination. His thought form was linear. There was no loosening of association or flight of ideas. In terms of thought content, he had some delusion of guilt because he thinks that he like he murdered the cat or he killed the cat. But there was no other deletion of reference, control, or persecution. He, is, he was oriented to time, place, and person. Insight, judgment was intact. He is high risk patient because he is having active thought of suicide. I was able to maintain a good rapport with my patient and his history is reliable. Okay, so this is how you should talk. Remember, in the exam, you have to present MSc in a format. Don't just go to and fro. I have seen a lot of candidates during the role play session, they just go to and fro. They don't maintain any format. And as an examiner, I feel difficult to keep a track that what are the positive finding he is talking about. So if you follow a format, examiners become happy because he also in his mind having this aseptic J3R. All right. So always try to make a format. So Dr. Sadaf, very good question. Rapport building is lost in psychiatric patient, but what if my patient is cooperative? If your patient is cooperative and answering all your questions, then well, you are able to maintain a good rapport. It doesn't mean that schizo patient doesn't maintain a good rapport. They can maintain good rapport. It depends that exact patient, how they are talking with you. Any questions so far? There are some examples I have kept in here. All right, now we will start the MSc exam cases just after 5 minutes. So I'm giving you some time just to like go through these things in your brain. Then we're going to start the MSc exam cases. All right, so 5 minute break and then we are going to start again. Just give me 5 minutes. Okay, so we'll don't go anywhere. Take some drink or try to think that aseptic J3R. Then we're going to start again. So let's start our MEC exam cases. So everyone is online. Let's see. Dr. Dr. Irsa Mujammal. So delusion of persecution is if a patient feels like someone is trying to spying on them or someone is trying to harm them, even sometimes if anyone feels like the others people are jealous about me, these are all included in delusion of persecution. Same is paranoid delusion. Both are same thing. Great. Let's start again. So, all right, what we need to assess in risk. In risk, you assess suicidal ideation, homicidal ideation, you assess active hallucination, active delusion. Four things is the vital thing in risk. Others, there are also others thing which if sometimes they ask like you need to do a risk assessment for that patient. That include a total other things like we call it SAT Pearson's, but we'll not discuss that today. We'll discuss it in other classes of psychiatry. So the first case is this one we already discussed. So a vet dog brought by his wife as he was trying to hang himself because a cat was died during a surgery. So we discussed that case already and we don't need to discuss it again. Now let's just start with the MSc video case. Let's see if you guys are able to find out what's the positive findings for this patient.
Hello, Alison Wells. Do you want to come and have a seat?
So let me say, first of all, the MSc video in the exam will be kind of similar like that. So they will give you a MSc video and they will ask you to present the MSc after finishing that video. That's pretty easy rather than taking a history.
Hi, I'm Dr. Taylor, one of the GPs at this surgery. What would you like me to call you?
Alison will be fine.
Okay, okay. So what's brought you here today, Alison?
My sister's noticed I'm just a bit fed up, really.
Right, okay.
My sister said I should come.
Right, okay. Has this been going on for some time?
Yeah, a few months, really.
Okay. Do you want to tell me a bit more about what's been going on?
Just things seem to be piling up.
Right.
I just don't seem to be coping with things.
Right. Okay.
The kids and things.
Right, okay. Would it be okay, Alison, for me to ask you a few more detailed questions about how you've been feeling?
Mm.
Okay. Well, if we start with asking you a bit about your mood, how have you been feeling in yourself?
I say a bit fed up.
Mm-hmm.
Wake up in the morning, everything just seems very black.
Right.
It's just like swimming in treacle, really, and
Right.
I think by tea time the kids get home, so I've been having a fairly decent conversation with them, but
Right. And can I just check, Alison, when you say things feel very black, do you mean you feel very miserable?
fed up, miserable.
Right. Okay. And what about sort of feeling tearful? Has that been happening?
I dropped some sugar the other day and I just burst into tears.
Right. Okay. So is it the slightest thing that would make you feel tearful? Things that perhaps wouldn't ordinarily bother you?
Yeah.
Right.
My sister's noticed as well.
Right. Okay. So you've been feeling very low, and with episodes of tearfulness.
Yeah.
What about other things? What about your energy levels? Are you managing to keep up with things?
I used to do a lot with the kids. We used to go swimming, playing, but now I just spend the day on the sofa really, unless I have to go to work.
Right. And just remind me, what is it you do for your job?
I work in the supermarket.
Right. So how have you been managing at work?
I'm not been going in as much because I just feel so exhausted. But I mean, we're just not. The supermarket's been taken over and they've cut the wages.
Right.
And I'm having problems with bills.
Right.
And it's like catalogues. They're just writing me letters. You know, the kids, they want all these new games and stuff.
Yeah, sure.
And it's just, you know.
It sounds like things are really difficult all round. Okay. With all this going on, how are you sleeping, Alison?
It takes me ages to go to sleep. I used to read a book.
Right.
And just drop off.
Right.
But now I just spend my time looking at the clock.
Right.
It just goes round and round.
So from actually getting off to bed and getting off to sleep, how long is that taking?
A couple of hours probably.
Right. Okay. Once you're actually asleep, are you waking up much during the night?
I wake up about, last night I think it was about 4 o'clock.
Right.
I woke up.
And can you get back to sleep from that time?
No.
And then when you're actually getting out of bed in the morning, are you still feeling tired at that point?
Just exhausted. I feel like my brain's not been switched off.
Right.
And I'm just exhausted the next day.
Okay. What about eating? What's your appetite been like while you've been feeling like this?
I used to have quite a weight problem, but the last couple of months, I mean, it's just a bit looser.
Right.
I just...
Do you know how much you've lost?
No. The kids come in from school and they make their own stuff and I just don't bother really.
Okay, so your appetite's gone down as well. What about things like concentrating in your memory, both when you, I don't know, watching TV at home or out when you're out doing your job?
Well,
how have those things been?
I've been pretty useless with the kids. I've got the swimming money last week and
Right.
PE kit and parents even.
Right, okay.
I just start one job and I'd like, I'm not explaining myself very well. It's like the television. I used to like watching the soaps, EastEnders or something, and now 10 minutes later I just, thinking of something else.
Okay. And what about things, Alison, that you used to enjoy? Are there things in life that you still enjoy at the moment?
Nothing really. As I say, a bit useless with the kids. I used to enjoy going out.
Right.
I used to go out with my friends for pictures and things.
Right.
But of course now I just can't be bothered.
So is it you can't bother, or you don't feel like it as well?
What's the point really?
Right, okay.
You know.
And I was going to ask, how old are your children now?
I had them a bit later in life. It took us a long time for me to have them.
Right.
I've got a girl and a boy. One's 11, one's 9.
And looking after children takes a lot of time and energy. How are you managing to keep up with that, feeling as low as you do?
Well, they're a bit self-sufficient really, the kids do. They come in from school, get their own tea.
Right.
I should be doing more for them really, but no, I'm just a bit useless at that at the moment.
Okay. And what about looking after yourself?
Well, you can see I'm just a mess. Dave used to say, that's my boyfriend.
Right.
I used to, not have much money, but I just take a bit of pride in what I was doing, you know.
Right, okay.
And my hair and stuff, but I can't be bothered with that now. There's no point really.
Okay. And you mentioned Dave, that's your current partner. How long have you and Dave been together?
About a year I met him at work.
Right. And how are things, because often when people feel really down, it has a real impact on everything, including their relationships. How are things between you and Dave at the moment?
But he's not ringing as much.
Right.
And he used to text. But he's going, he's getting fed up with me not wanting to go out and things.
It's a slightly embarrassing thing to ask about, but I guess it's important. Often when people are really feeling very low, it affects everything in their relationship, including things like the sex life. Have you noticed any changes there for you?
He's always trying to pressure me a little bit and stuff, but I'm really not into that at the moment.
Okay, you just don't feel like that at the moment. Okay. So can I just recap, Alison, and check I've got this right?
All right. So this case is like more related to the depression. As you can see, they are not asking a lot of MSc related question. Now, sometimes during the exam, you will find that most of the talking that they are doing in the video are not related to the MSc. And that just to make you confused. You just need to pick up the aseptic J3R from the conversation. You don't need to talk about sleep, appetite, sexual drive. You don't need to talk about lack of energy, lack of concentration. These are not part of the MSc presentation. So you don't need to do that. You will just say according to the aseptic J3R, and others you will just say that there's a not assessed. Now, those who are in the Zoom, is there anyone who is happy to present the MSc for this case? Then I'll show you that if we can improve it anyway. And just to add with the video, I would say that this patient doesn't have any suicidal risk. Okay. What's the name of you, doctor? Your name showing as a computer. Sorry for that. But what's your real name? Who has written me? Dr. Najia, please come online. So we'll see. I'll just computer. Okay, I'm allowing you to open your audio. Now you should be able to talk.
Yeah. Hello. Yeah.
Hi, Dr. Najia.
Yeah.
So please go on. So I'll give you 2 minutes time to present the MSc.
Yep.
And in the 2 minute time, you can present. Please go on. Start.
Now start?
Yeah, start.
Okay. I would like to, dear examiner, I would like to present the mental state examination of my patient, X, 50-year-old, who is presented to me with a complaints of low mood. So on general appearance, my patient is sitting comfortably, well dressed according to the weather, well groomed, and she's cooperative, though she does not maintain adequate eye contact with me. Very often she is her gaze is to and fro, and she is maintaining a stooped posture, as well as some a continuous movement of her few fingers, showing some anxiety. And so Regan, and her speech is slow, monotonous voice, and sometimes take a pause and low tone, and speech. And regarding her mood, her mood is low, and the affect, what I observe, that is congruent with the mood. And perception, she does not have any visual or auditory or tactile hallucination, and or perception, I can say, not assessed. And regarding thought form is linear. There is no present of no loosening of association, no tangentiality, no circumstantiality. And regarding thought content, she she does not have any.
Your time is up, but yeah, please continue.
Oh, she doesn't have any overvalued ideas or obsession or delusion, like delusion of guilt, delusion of persecution, and delusion of grandeur. And she is not at risk of suicide. She doesn't have any suicidal plan or no past history and no definite plan. and she's living with her two kids, and she's so seems she's not at risk of suicidal or homicidal, and history is reliable to me. I was able to maintain good rapport with my patient, and history seems to be reliable, and patient is oriented to time place person, and patients oriented to time place person in judgment. Patients judgment is okay, and patient yeah, inside judgment is okay,
All right.
normal.
Thank you, Dr. Najia. It was very nice. But all right, like first of all, see that we have to prepare it, like we have to be very much, like I would say the time is very important in here. They might not give us like 4 minutes for MSc presentation.
Yeah.
Sometimes what happens, like we might get like most of the time 2-3 minutes for MSc presentation. But during the video presentation, usually what happens, 4 minute, they usually give you a video and 4 minutes for presentation. So it becomes easier in video, but I was just saying about the face-to-face, the history taking cases, in that time, usually you may not finish the history even in 6 minutes. So you have to be very fast, like you have to try to finish MSc in 2 minutes max. So
Yes.
it will happen. It will happen with a lot of practice and a lot of role play. You will see that it's very easy to finish in 2 minutes. Now you said most of the important topic, most of the important findings. So you said about the appearance. Okay, that was good. That you said about the patient is having some stoop posture sometimes, and so you can say sometimes maintaining eye contact and sometimes not. So as you said, another one was very important, the finger movement. So just in one word, say that patient also showing some fidgeting movement of the hands. That movement
Fitting
she was
movement.
doing is the fidgeting movement. Yeah.
Hmm.
And then your speech was slow, monotonous. She was taking pauses in between. According to the emotion, her mood was, so as I say, the mood will be whatever patient says, that should be the word. So according to the patient, her mood was miserable, low, and she was quite tearful. These three words they have used there: miserable, tearful, and low.
Oh,
And
low,
the affect
tearful,
what I have,
miserable. What patient said. Yeah.
yeah, whatever patient will say in when you ask that question, you have to just say that according to the patient, her mood was like that.
Yeah.
And then say that perception, it was not assessed. So say that perception was not assessed, thought form was linear, and the thought content was also not assessed. Just in a very easy way, we can just say not assessed, not assessed. Also, in here you can say insight was not assessed formally, but from the from the history, it seems like patient is having a good insight because she's here for help. Cognition was not assessed, judgment was not assessed. And then the patient is most likely, I would say this patient is of moderate risk because she doesn't have any suicidal or homicidal, but it's still it's affecting her life, right? So it's not a mild depression, it's moderate to severe, but I would say moderate. Severe only say when the patient is having suicidal or homicidal ideation. So this patient is having moderate risk because it's affecting her daily life and she's quite miserable according to her. The doctor was able to maintain a good rapport with the patient and her history seems to be reliable. So this is how we will finish this case. But you did great. You found out all the positive findings and that's great. So just need to do some more role play with your study partners and you will be fine. Thank you.
Yeah. Thank you. And I have some disorganized, like 3 hour I'm telling
Yeah.
before, then later I'm inside judgment cognition. Is it
It's
harmful?
not like I would say it's not like what we would expect, but it will not cause any harm. But like if you miss something, examiner will not like it. Like what we'll do, like sometimes if you follow the whole format and it's very clear and you are not like like having any confusion whatever you are talking, you are confident in your voice, then sometimes if you like just like do some flipping between these aseptic J3R, that's fine. But
Okay.
other things should be then very, 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 very perfect.
Judgment.
Okay.
Yeah.
So should we mention no flight of ideas or listening the thought form is linear? Okay. Now, Dr. Nisha, that's a good question. So usual, if you get some time, then try to say some of the negative findings. That's usually a very good way to present MSc. But if you are running out of time, just say the positive findings. Don't bother with the other negative finding. But normally, I would expect you guys to do that. Well, thought form is linear, but there is no flight of ideas or loosening of association. By this way, you are letting the examiner know that you know these things. Okay, so examiner feels like, well, this examinee is good enough to pass. So it's a kind of mind trick, like you have to be very good actor. You have to like manipulate the examiner. So it's important. It's these sort of things like you are kind of selling yourself in front of the examiner. So you have to sell in a better way. Okay. So I'll just mute Dr. Najia. Let's move on. Okay. The next question. You are a HMO in ED of a major hospital about to see a 28 years old man who had been brought to you by the police from the street. He is a schizophrenic patient on antipsychotics. He doesn't take his medication regularly. He admits taking ice at times, so it's a recreational drug also. Take history from him, present MEC to the examiner. Normally, this will be the case. They don't ask risk assessment with this case, and management is not usually commonly asked, but still we will let you know how to do that. So this sort of case, it seems like a schizophrenic patient. So patient already on antipsychotics is not taking any medication. On the top of that, patient is like doesn't have any shelters. That's why he's from the street. So a lot of things are important to look at in the STEM. So in here, you will introduce yourself and then you will give the confidentiality statement. So you can say that, well, John, I'm going to ask you a few questions, but I want you to know that whatever we are going to discuss, it will be confidential. I want you to know that you are okay to share everything with me. You don't need to feel judged. You don't need to feel blamed or ashamed about anything. I'm happy to know whatever going on in your mind, and I can assure you that's always will be confidential unless it is harmful for you or others. So then this is a MSc case. In MSc case, don't bother with like asking sleep appetites and asking about energy, concentration. Don't bother. Just follow the usual pattern of question. But sleep appetite, I usually keep it just to move on with the question. Mood, sleep appetite, suicidal risk. I usually make it as a format. Okay, but if you even forget to ask about sleep appetite in a MSc presentation case, that's totally fine. So main question will be, you need to ask about the E, which is emotion. So ask about, so John, tell me, how is your mood these days? Patient says, okay. Anytime you feel high or low? No, doctor. Good. How's your sleep and appetite? Patient says, okay. The next question is suicidal. So do you think your life is worth living? Yes, doctor. Have you ever thoughts of harming yourself or others? Patient says, no. Why I would do that? I am the messenger of God and God is asking me to do good to everybody. Now you have got your finding. So what is the patient is having? Hallucination. So the next question will be hallucination question. So already patient has given you some clue. You don't need to ask again, do you see, fear or hear things that others don't? So you just move on with the question, say, do you hear God? Yes. How long this has been going on? Very important to ask the duration, because to diagnose anyone with schizophrenia, that symptoms should be more than 6 months, right? So you have to know the duration. If it is less than 6 months, okay, so between 1 to 6 months, if the symptoms is going, then this condition will be schizophreniform disorder. Less than 1 month, we call it brief psychotic disorder. So that's why duration is important to ask. Then any other commands that you hear from the God. We are always, if a patient has auditory hallucination, try to ask any comment present or not. Sometimes they can get comment from someone to kill a person. So that command hallucination is a very important finding. You should always try to find out. So any patient having hallucination, command hallucination, you should ask like this, like, do you have like any other commands you hear from God or anyone else? No, just to do good. Any other strange thing that you hear apart from God. So any other hallucination patient is having, you can ask. After asking the auditory hallucination, rule out visual hallucination. So apart from hearing the God, can you see God? No. So this patient is having only auditory but no visual hallucination. So this is the main finding. Once you get a positive finding, you need to go into the detail of that positive finding. Then go for the thought content. So you asked about hallucination, now thought content is delusion. So ask about all those delusion questions related to schizo. So do you think someone is trying to spy on you or harm you? Patient says no, but I think all the people are jealous of me because I am the messenger of God. So delusion of jealousy is a subtype of paranoid delusion. So just say that this patient is having delusion of persecution or persecutory delusion. So if you ask why, then patient says, well, I'm the messenger of God. Then quickly ask about all other delusion question. So delusion of control, delusion of reference, ask about thought insertion, broadcasting, all those things. Then after thought form, then you have insight, cognition, judgment. So ask, do you think you need some medical help? Patient will say no. Then what you will do if this room catches fire? Patient will say nothing, God will save me. And then cognition. So can you tell me where are you at the moment? Patient says, yes, in the hospital. Do you know who I am? Do you know what is the date today? Okay, so that's usually completes your MSc. If you don't get enough time, you don't even need to ask heads or SADMA. But if there is any other things like you have to give diagnosis or you have to do the risk assessment or you have to say the management, then you need to ask the heads and SADMA. So in the heads, again ask about home situation. Patient says patient lives in the street in a refugee camp. Financial issues is there. Patient usually gets help from the central link. Okay. In the SADMA, patient says taking alcohol, also taking ice. Now, if a patient taking ice or any recreational drugs, you have to make sure that since when patient is taking it to rule out drug-induced psychosis. So when was the last time you took it? Patient says last week. How many times you take it? Patient doesn't have enough money. So obviously this patient will not take a lot of ice because it needs money, right? So patients say, often I will take it. Not no any part there is no particular like routine or schedule for taking that. Any other street drugs? No. So this is important to ask that how long patient is taking the ice and when was the last time patient took it. So because if it is last week, patient took the ice and after 1 week, ice should not cause this problem today, right? So this is not a drug-induced psychosis. You just rule that out. And then remember the in here it says that patient was on antipsychotic and not taking medication now. Ask that. So I know from the notes that you have been on antipsychotic medication. Can I please ask that why you are not taking that medication? Patient says, I don't need to do that because I'm the God messenger. God will save me. Why I would need medicine? Okay. So these sort of questions are important. And lastly, past medical history, family history, and rule out organic causes. But if it's only a MSc case, you can even finish in here. up to judgment and cognition. Okay. And then you will present. So in here presentation, already you know that how you will present. So say that, well, I'm going to present the mental state examination of my patient, a 28-year-old gentleman brought by the police from the street, reason being unknown. Whatever the reason it will be in the stain, you can add it here. In terms of appearance and behavior, he is not appropriately dressed according to the weather, seems unkempt and ungroomed, not well groomed. He is not very cooperative, but he was maintaining eye contact with me. If there was any responding to unseen stimuli, also say that, well, patient seems to be distracted and responding to some unseen stimuli. The speech was normal in tone, volume, and rate. There was no disorganized speech. Okay. And then say about emotion. Patient says his mood is okay, and the affect that I have observed is not congruent with the mood, because his mood is not okay. His mood is disturbed. Schizo patients' mood is never ever okay. Their mood is always disturbed. So always say that his mood seems to be disturbed. So I think the affect is not congruent with the mood. After the emotion, then in terms of perception, patient is having auditory hallucination because he thinks he can hear God and he is the messenger of God. But he doesn't have any visual hallucination or tactile hallucination. In terms of delusion, he has delusion of persecution because he thinks people are jealous about him. And also, what is the another delusion patient is having, guys? Yeah, very good. Delusion of grandiosity, right? Because patient thinks that he is messenger of God. That is thinking that he's having some special power or superiority. So he's also having delusion of grandiosity. It doesn't mean that always mania patient will have grandiosity. Schizo patient can have it also. And thought form was linear in this patient. And then he is oriented to time, place, and person. Insight is poor, and judgment was also poor. Okay, and if then just 3R. In this patient, what will be the risk? Is he a high risk or low risk? This patient is having active hallucination or delusion. So this patient will be high risk. So you will say in terms of risk assessment, this patient is of high risk because he is having active hallucination and delusion. Now, sometimes if risk assessment is a sole task in the exam, then you have to add something else. For risk assessment, we actually look for some other things apart from suicide, homicide, hallucination, and delusion. What are other those? We look for if the patient having any support. So if this patient is having any support or not, any spouse or any family. Is there any history of drug abuse, mainly illicit drug? Okay. Is the patient is having any insight or judgment? And is the patient is having any financial issues? If a patient has suicidal ideation, if he has any active suicidal plan. Usually we follow Seth Pearson for that, but normally you will not get that much time in the exam to do that. Just remember, you will look for these things in a patient. So in this patient, obviously he's high risk because he's having active hallucination and delusion. He's not compliant with his medication. He doesn't have any insight and judgment. He abused illicit drug. He has no proper support, okay, because he's living in the street, and also he has financial issues. So all this put him in the risk. Management, as I said, normally doesn't come in the exam, but what if it comes in the exam? How to manage a patient who is showing active hallucination delusion? We divide it into immediate management and long-term management. In immediate management, this patient needs urgent admission in the hospital because he is a risk to himself as well as to others. So you will say in terms of immediate management, this patient requires admission in the hospital, followed by complete organic workup to rule out any medical causes. So just full blood count, ESR, CRP, kidney function, liver function, thyroid function, toxicology screening of blood and urine to rule out any drug abuse. And then he needs to be assessed by the mental health team in the hospital. Mental health team in the hospital comprises of psychiatrist, psychologist, and a mental health nurse. So psychiatrist will put him on antipsychotic drugs, psychologist will give him CBT, and mental health nurse will assist him during his stay in the hospital. In long term, patient will go home when he is stable, but he will need a constant community health worker to care her in the community, and also will need to arrange a social worker for him. And then he needs to be reviewed by the GP and psychologist and psychiatrist regularly. That's the long-term management. The important thing in here, like, it depends on if the patient is in GP setting or ED setting. If a psychiatric patient or a patient who is having active suicidal ideation, that means high risk patient, if they are in the GP setting, your task is to call crisis assessment team, CAT. So crisis assessment team will interview the patient over the phone sometimes and also talk with you, and they will assess the patient if this patient needs to be admitted in the hospital. If they think that this patient needs to be hospitalized, they will arrange all the things for that patient. So you just need to send that patient to the hospital at that time. If the patient is in ED setting, then you don't need to arrange for a crisis assessment team. You just need to refer the patient to the mental health team in the hospital, and they will assess the patient and they will admit the patient under their care. So this is a little different between ED setting and the GP setting. Clear? So we did discuss about the MSc video, we discussed about a MSc schizophrenia case. Now we are going to discuss another case, which is a MSc video. Young man think his mom is having sexual relationship with his uncle, and you need to present MSc to the examiner. So that video case is a video case of OCD, obsessive compulsive disorder. So the obsession is like patient think that patient mom is having sexual relationship with his uncle. Okay, and to resist this thought, he needs to do some compulsive behavior. So in this case, this could be your positive finding in the video. So appearance, so if the patient is dressed appropriate or not, well groomed or not. Sometimes throughout the conversation, he was keep playing with his both hand. That was the fidgeting of the hand. Because OCD patients are quite anxious, they usually have this sort of abnormal movement of their body. He did not maintain any eye contact, was keep looking at the floor, looking worried, but he was cooperative and answering everything. Regarding his speech rate, like speech will be normal. It will not be rapid pressured or anything. And then mood, patient said I'm worried, and affect will be congruent with the mood. Regarding perception, there will be no hallucination in OCD case, and the thought form will be linear. Thought content, now in thought content, you will get the finding, right? So only thing positive in here will be the thought content, that he is having obsessional thoughts that he thinks his mom is sleeping with his uncle. He also said it's impossible, but he cannot get rid of it. Whenever this thought comes in his mind, he needs to stand up and move around. So this was the compulsive act. but he doesn't have any other delusion. So you just need to stop like this. So in terms of thought content, he is having obsessional thoughts as he thinks his mom is sleeping with his uncle. He also thinks it's impossible but cannot get rid of it. This means that this is not a delusion because patient know that it's impossible. So it's not a delusion, but rather it's a obsessional thought. Okay, and the compulsive behavior was that whenever this comes in his mind, he needs to stand up and move around. Regarding the insight, obviously patient comes to you and talking about all these things, and patient think that it is impossible. So insight is intact, and others will be also intact, like judgment will be intact, cognition will be intact. Sometimes this will not be even assessed in the video. If anything is not assessed, don't comment by your own. Very important. Sometimes just because we think that it will be present in the video, we just comment. But if it is not assessed at all in the video, don't comment, just say it was not assessed. That should be the good approach. Clear, everyone? Any questions? So I guess someone asked me about the difference between the ED and GP setting. So any mental health patient who is high risk patient, in the GP setting, you need to call the crisis assessment team, CAT. Crisis assessment team will talk with you and also with the patient. They will assess the patient if they needs to be hospitalized. If they think that this patient needs to be hospitalized, they will ask you to send the patient to the hospital and you will do that. In the hospital, that patient will be admitted under mental health team. That means the psychiatrist, psychologist, and the mental health nurse will take care of her. If the patient already in the ED, you don't need to call the crisis assessment team. You can just start with the mental health team. All right. Now clear, everyone? Any questions so far? Now I'm going to show you how to do a difficult role play, and just listen that how during difficult sessions or difficult cases, how you should keep everything calm and confident, and don't just bother whatever the patient is talking about you. Okay, just keep in mind that I need to finish this task. I need to find out the aseptic J3R from this patient. So is Dr. Maria is here? Can I ask you, doctor, please, to help us with this station? Good. All right. Thank you so much for helping. I will just unmute you. Can you
Hello.
hear me, doctor? Yes.
Yes.
All right. Dr. Maria, so this is the case. So what you need to do with me, that you need to be my patient. So you'll be a difficult patient in this case. And
Yeah.
then also I will be just a examinee in here. So you see that this is the question is that you are like this is a HMO in the surgical ward, 47-year-old patient who had a surgery done for dislocated right shoulder, currently behaving oddly in the ward. He is reported to see cockroaches. He is aggressive, difficult to settle. Surgery was done 1 day ago and there was no complication. Adequate pain relief was given. Patient has a long history of alcohol intake. Patient is a non-smoker, no significant history. Perform a psychiatric assessment and present your finding and MSc. Mainly this will be a case of MSc. So remember, sometimes MSc they can ask that psychiatric assessment. It's the same like MSc. All right, so I'm going to stop sharing this thing. So we'll do just role play. Just hang on. Are you ready, Dr. Maria?
Yes.
All right. So we'll take 8 minutes or 7 minutes 30 seconds for this one. Just give me a sign. So in this case, so when I say that it's start, all right, Dr. Maria, when I say start, we will
Yes.
start the station and you will try to, like, we cannot open the video here because of some purposes. So what we need to be here, so it will be like, normally it will be better when we do it in our classes, face to face will be a good idea. So, but in here, you will try to show, not to show, you will try to pretend that you are hitting cockroaches and I will just start in that way.
Okay.
And your name will be, well, Maria will be a fine name. So, okay,
Yeah.
start. Hello, Maria. This is Dr. Arshan, one of the doctor here. I can see you are hitting the cockroaches.
Yes, doctor. The place is too much dirty.
I'm really sorry for that. Please don't worry. I'm just calling someone to just to clean the room. It should be fine. I'm really sorry for these sort
Please
of
do
things.
it as early as possible. I can't tolerate this.
I understand. I understand so much. Like, I'm really sorry for that. Please come down, just have a seat, and let me discuss whatever making you uncomfortable. And I want to assure you that the cleaner will be here just within minutes. And please understand that whatever I'm discussing with you, that should be confidential between you and me.
Do it. Please do it.
Yeah, I can see you are hitting the cockroaches. Where are you seeing those cockroaches?
Doctor, cockroach is all over the area. In my hand, in the table. Oh, doctor, there is a cockroach over your shoulder.
Oh,
Please hit
oh
it.
my God. Yeah, I'm really sorry. Yeah, this place should be very uncomfortable for you. Is this cockroaches also crawling on your body?
Yes, doctor.
I'm really sorry. Yeah, yeah, cleaner will be just within few minutes. I just call them and they will be here. I'm really sorry for that. So, is there any other things making you uncomfortable?
No, that's the cockroach and it's very much irritating.
Are you hearing any voices, Maria?
No, no,
Okay. Is there any other things you can see that others don't?
no, doctor.
Okay, all right, that's good. And how is your mood right now?
Mood is good, no problem. Only the cockroach is the problem.
Yeah, I understand. That should be really, really uncomfortable for you. I understand your position. Should not be like that in the hospital. Please try to bear with us. Cleaner will be here anytime.
Okay.
Anytime, do you feel very high or low?
No, doctor.
Any thoughts of harming yourself or others?
No,
Okay. Do you think someone is trying to harm you?
no,
Any thoughts of that someone is controlling you?
no,
Anyone trying to insert thoughts or take away thoughts from your mind?
no,
Do you think that like you are guilty about something or you are having some special power?
no.
All right, good. Thank you so much for answering my questions, Maria. And do you think that your thoughts are broadcasted to some newspaper or televisions?
No, doctor.
All right. And if I ask you that if there is a fire in this room, how you are going to feel?
Is there any fire? I have to run.
No,
Show me
no,
the
it's
way.
all right. It's no. Please calm down, Maria. There is no fire. I just assume that what you're going to do. All right, that's good that you want to run away. And Maria, do you think you need some help from medical team?
Oh, for the surgery only. Apart from that, nothing is important for me.
All right, that's great. And do you know where are you at the moment?
In the hospital,
Do you know who I am?
you are the doctor?
Great. And just a couple of questions like, do you smoke or drink alcohol?
Ah, I drink alcohol.
How much?
3 or 4 glass per day.
Okay, if you give me some consent, then I would like to talk with you in detail after these consultations. That should be fine.
Okay.
Do you use any recreational drugs, Maria?
No.
Good. All right. Thank you so much for all the information, Maria. And yeah, so that's fine. Now, this is the time when we will do the MSc presentation. So, dear examiner, I would like to present the mental status examination of my patient, Maria, a 33-year-old female who was behaving oddly after surgery. She was dressed appropriate and she was well groomed, but she was not responding totally during the questions because she seems to be distracted by some visual hallucination every now and then. Her speech was normal in tone, volume, and rate. She described that her mood is okay, but affect that I have observed, it seems to be disturbed and not congruent to her mood. She is experiencing visual and tactile hallucination because she is seeing cockroaches as well as she feels cockroaches are crawling on her, but she doesn't have any auditory hallucination. Her thought form is linear, no loosening of association, no tangentiality, circumstantiality, or flight of ideas. In terms of thought content, she doesn't have any delusion of persecution or delusion of control, no thought insertion, withdrawal, or broadcasting. Her insight and judgment are impaired. He is or she is oriented to time, place, and person. I was able to build a little rapport with the patient. In terms of risk assessment, she is of high risk because she is having active hallucination. Her history was unreliable, so I would like to talk with the doctor who is looking after this patient. All right, thank you. So this is how you should present the MSc. I may miss some things, but if you just cover most of the thing, that should be fine. All right. So thank you, Dr. Maria, for it was very good. So this was in these cases, you have to be very careful that how you are preparing, how you are talking, and the in the exam, the role player will be much more complicated than us that how we do because they are professional actor kind of, so it will be really hard. So make sure you just need to ask questions related to the MSc. That's the main thing. Oh, the voice was interrupted. I'm really sorry for that. I don't know how it happened. Okay, anything you want to ask from this case? So this case will be like this, similarly how we did. Nothing much to add here. So whenever the patient will hit the cockroaches, and just to make sure you find out the tactile hallucination and also the visual hallucination, and just whenever patients say cockroach, cockroach, you just reassure the patient and say that it should be very, very stressful for you. You must be very uncomfortable. I'm really sorry. I have already called the cleaner. He's on the way. Just say that, okay? You don't need to call, okay? You will just need to say. In this case, no judgment, no insight. Because why? When I say that, do you need any medical help? Patient say no, because this patient is having like only this sort of odd behavior, and she doesn't think this needs to be helped. And also during the judgment, when I say that in these patients, like what you are going to do. Now, in this case, judgment, you can say intact because patient wanted to run, okay, but it was kind of like concrete thinking. You can say this particular judgment is called concrete thinking, which means that patient did not understand what I tried to let her ask, right? I asked what you would do if this room catches fire. Patients say, oh, there is fire. Okay, so these are called concrete thinking. But as the patient wanted to run, you can still say that yes, patient's judgment is intact, but she is having concrete thinking. Clear? So we just did the MSc presentation. We did not did the diagnosis or causes. Now, if it is diagnosis and causes, the diagnosis in this case will be delirium due to alcohol withdrawal, because this patient is after surgery showing some delirium. All right, and this will be like due to alcohol withdrawal, patient is behaving strangely. That is called delirium due to alcohol withdrawal. Other than this, it could be anything else. So you can say drug-induced psychosis, schizophrenia, schizophreniform disorder, bipolar disorder, mania. So all those DD you can say. Yeah, it's okay. Dr. Nanali, yes, it's okay to say that you are calling a cleaner, even it's untrue. Yeah, these are for reassurance. Psyche patient, you need to handle them. So you have to provide those sort of things. Otherwise, you may not be able to get any answers from them. So psychosis and schizophrenia is kind of same thing, right? Schizophrenia patient is a subtype of psychotic patient. Now delirium, this particular case, why we kept it as a delirium, because this is just after the surgery, patient is behaving strangely, like having some hallucination. And hallucination, mainly visual hallucination, is a part of delirium, perceptual disturbance that is common. And this patient had a long history of alcohol intake. So during the surgery, patient could not get any alcohol, and that's the reason of the delirium. Okay, but same case, if it was not a post surgery and for a long time patient is having the same hallucination, that means at that time we would say schizophrenia or schizophreniform disorder, depending on the duration. So it's case by case, we have to say our diagnosis. Clear, Dr. Shirisha? Good. Next case, young patient comes with change in behavior. Patient has history of schizophrenia from illness. Do MSc, present MSc to the examiner. So young patient comes with change in behavior. So this case, it was a 4-minute video. Patient had auditory hallucination and delusion of grandiosity, delusion of reference, homicidal ideation, thought insertion. So remember one thing, it's very hard to say that what was the case or what, there can be any case that can come in the exam, as long as you know that how to ask questions and how to say MSc to the examiner, you are good. Another case was like assessment of change in behavior, same. So in that case, if you go through the MSc findings, then you can see the appearance, patient was dressed, but had some disheveled hair, which is kind of unkempt hair, fidgety and distracted behavior, was cooperative, wearing sunglasses, so you cannot comment on eye contact. So if a patient is wearing sunglasses, in the appearance, you have to obviously say that, because that's the reason you cannot comment on eye contact. His speech was pressured, emotion was not assessed, perception, she was having some auditory and visual hallucination because she was talking to someone during the whole conversation. In the thought form, there was loosening of association, if it is otherwise say linear. Thought content, there was deletion of reference, deletion of grandiosity, and deletion of persecution. Insight was impaired, cognition judgment was not assessed. Risk, patient had homicidal ideation having hallucination and delusion. So he is a high-risk patient. Rapport was not built properly and history was not reliable. So you need to take a collateral history from others. Another case, university student. She has been previously diagnosed with schizophrenia disorder, did not take any medication, now presenting with behavioral changes. All other physical examination was normal. Take psychosocial history, present MSc to the examiner, tell diagnosis and differentials. Anyone wants to do the role play with me? That means you will do the case. I will be the patient. Anyone? Is this Dr. Najia? So I think you already did one. I would say like if we have anyone else to do that, we want to give the option to everyone. Who is user name? I can try. Who has written I can try? Your name is here is shows that is user. Is it Lin Tan? Okay, Dr. Mukta Dash. Yeah, sorry, Dr. Lin. Dr. Mukta actually asked at the first, so we'll start with her. So, Dr. Mukta, I'll just open your mic.
Hello.
All right. So you already know that this patient is a uni student having some schizophrenia disorder previously and did not take any medication. And now she's having behavioral changes. You need to take a psychosocial history, present MSc to the examiner. I will just keep it up to here. No need to tell this. Okay. So up to MSc presentation you will do. I will stop sharing and just give me some time. Uh, there is some noise coming out from you, Dr. Mukta.
Can you give me just a moment? I will.
Yeah, sure.
Just one.
Yeah, that's okay.
Hello.
Yeah.
Now it's okay.
No, it's still a little noisy sound coming out.
Okay, then
Is
I will try later. Better.
is everyone is hearing the sound, or is it just me?
Dr. Arshan,
Yeah.
I think if anyone can try, it's fine for me.
All right. Okay. Dr. Lin, do you want to try? Yeah. Please come in. Sorry, Dr. Mukta. We'll
No,
try
it's
again
okay.
in other class. Okay.
Yeah.
Why I can't find you, Dr. Lin? Where is your... Okay.
Yeah, can you hear me?
Yep.
Yeah, thank you. So,
All right.
what should I do
So,
now?
have you seen the question already?
So, does the medical students have the schizophrenia form?
Yeah.
Then,
So there was a university student came with behavioral disorder, and he had a history of schizophrenia disorder previously. He's stopped taking the medication,
yeah,
and now you need to take the history from the patient and present MSc to the examiner.
okay, yeah.
Okay. All right. I'll just start your time. We'll do it in a 7-minute time. Do you want some time in the outside, like 1 minute to prepare yourself?
Yeah, if I can. So,
Yeah, sure. So your 1 minute time is started, and then when I say hello, doctor, you will just start. Okay.
yeah, thank you.
No worries. Hello, doctor. Can I check your ID?
I can, here's my ID.
Yep. So this is your patient, Mike. You can start.
Thank you, examiner. So, good afternoon, Mike. My name is Ling Swan. I'm the doctor in the hospital today. So,
I'm coming, President. I'm just here. Wait a minute, President. Yes, yes, yeah. I'm coming. I'm just at the hospital. Yeah, sir. I just need to come to you. I know the world is going to end, and I need to help. Yes, yes,
oh,
President. Just forgive me for my delay. It's just that all the doctors are just trying to make the delay. I think they are a part of this problem. Okay. Yeah,
oh,
I'm coming.
that's that's okay, Mike. Oh, thank you. It seems a very interesting idea. So, Mike, would you mind to have a seat and then we talk more about that?
Oh, we
Are
don't
you
have
okay?
any time, doctor. Like I need to save the world, and just the president called me. You've just seen, so I need to go. Please don't make any delay. Already I'm totally delayed, and the world is going to end. I need to find a place for my wife and for my daughter.
Oh, I understand that you are busy now. So, I would need to ask you a few more questions. So, can you have a bit of time so we will discuss a bit more about that? Are you okay with that?
No, I'm not okay with that. How can be okay when the world is going to end?
Okay. So, I just have a few couple of questions and then we will go detail with the plan. Are you okay with that?
Yeah, go on, doctor.
Let me reassure that everything discussed with you guys will remain confidential unless come to your order. Are you okay with that, Mike?
Yeah, go on. I know you guys are part of it. Yeah, go on.
Oh, yeah. Could you please tell me how about your mood today? So from 0 to 10 and 10 is the highest, which number would you give
I'm
to me?
okay. I'm okay.
Okay. And then how about your sleep recently?
Yeah, I can't sleep a lot now. When I know that this world is going to end, I can't sleep. No one can sleep.
Right. So you think you don't need to sleep at all. All right. And do you still enjoy things you enjoyed before?
Yeah, yeah,
Hmm.
I used
Yeah.
to.
All right. Yeah. So I will ask you a bit more screening questions. So in a difficult situation, some people may see things or hear the things that the other people can't. Do you think that applies to you?
What do you mean? I don't know. I can't do that. I don't do that. But the president is talking with me. You can see that. So what is the
Right.
big deal about that?
Oh, so you hear the voice, or it means that, or it's come to your mind that you have the special
No,
power. That's,
No, no. What do you think? Do you think I'm some kind of crazy, stupid person? I'm not like that. I'm a special
Sorry.
person, and that's why President is calling me because he knows that I'm the only person who has the power. I have the power like Harry Potter, and I think I am the only person who can save this world.
Oh, sorry, I didn't mean that. So this he talked you, asked you to do something.
He wants me to save this world.
Okay. And did he ask you to harm yourself or harm another people?
No, he wants to save the world. What are you thinking?
Right. And then, so do you think you have the special power to do that?
Yeah, I say that I'm like Harry Potter. You've seen Harry Potter, right? So yeah, I'm having power, and that's why President is relying on me.
Yeah. So do you think that someone talking about you, like from television or radio, they're talking about you?
No,
Okay. Do you think that's there's someone trying to harm or spy on you?
no,
Or do you think there's someone trying to insert or withdraw the thought from your mind?
no.
Okay. Do you in difficult situations, some people might think about harm or themselves or harm the other people. Do you think that applies to you?
No, why I would do that? I need to save others.
I understand that, right? So do you think you need the medical help?
No, who needs medical help when you have power like Harry Potter?
Okay. And then do you know where you are now?
I'm in the hospital. You just guys are making it delay to save the world. This you guys are a part of it. I know. President told me about that.
I'm sorry about that. So we will address about your idea later on. So do you know who is talking with?
I'm talking with you.
All right. So you don't know who am I?
Yeah, you're a doctor.
Okay. And do you know what's the day today?
Nah, I think it's Sunday.
Okay, that's good. And then now, if there's a fire in a room, what will you do?
I can stop fire. I have the power to do that. No fire can touch me.
Understand that. Okay. And how about your home situation? Who you live with?
I don't have anyone. No, like I had my daughter and wife. They just left me.
Okay,
They
so
don't
this means
want my
you
help.
go. Okay, I'm sorry to hear that. So this mean that you don't have any family support at home.
I don't need anyone's support. I'm, I'm having all these powers. I don't know what to do with these.
I understand that. So do you have any? What you working now? You're working or studying now?
No, I don't need that.
So with financial, I mean, how can you live with?
I'm just okay.
Yeah, okay. And then do you drink alcohol?
I don't know.
Any illicit drug by any chance?
Might be. Not sure.
All right, yeah. So you have the diagnosis with schizophrenia form, and you stop the medication. So where can I ask why you stop that?
Who needs medication? I'm having a lot of power, and everything I can cure myself. So why I would take these stupid medications? Those make me sick.
Okay, okay. So thank you very much. So thank you very much. So can I for your cooperation? So can I go with the examiner?
Yep.
Okay, so the examiner today I assess Mike, a university student who come because of change in the behavior, and he has a history of schizophrenia from, and he stopped the medication by himself. So in the MSc assessment, from appearance, I can see he well-groomed and also kempt, and has.
Uh, so don't worry. I'll give you 1 minute time because your 7 minute is out. So you'll get 1 minute time to finish. So be quick. All right, start.
Yeah, so thank you. So he's cooperative, he's maintained well eye contact, and also, and his speech is a bit high and pressure speech, and his emotion, his why his emotion is normal, but I can see it's from the top, he's a bit high, so it's a bit not congruent, and he has the hallucination of auditory, and also in the talk content, he have the illusion of grandiosity, and also the talk form is a kind of the fly up ideas, not very well association, and his insight was impaired, and his orientation was good, and his judgment was impaired. So I can create good rapport with him. However, it's not reliable, and it's cholesterol as well. And in the risk assessment, he's at high risk because he has active hallucination of auditory, and he has no support at home as well, and he stopped the medication himself. So I will need to admit to the hospital. Um, Thank you, Examiner.
Yeah. Thank you so much, doctor. It's very nice, Dr. Lin. I'm really like, it's good. I would say that you did really good in the history session, and that's very important to remain calm and confident when you ask the questions and everything. Mm, that sometimes the role player will try to confuse you, will try to irritate you as much as they can, but you have to be like really calm. Don't bother whatever they are saying. So you did really great. That's good. And try to finish, because if it's a MSc case, um, you don't need to even go for the heads or any other drug, because if you would not go into that, then you could finish it in time.
Oh,
See that
yeah,
the in the exam, when they make up a task, they know that how much time you will consume, and in that way they make the station. So that home situation, then sadma, this actually killed your about 30 to 45 seconds that you could easily utilize in the MSc, and then
yeah,
you will be able to finish it in task.
yes. It's even more than
Because they will, yeah,
yeah.
yeah, so they will not like like cut down your mark or anything, because you're just asking the MSc. So that should be fine. But if you get time, then obviously, yeah, it's good to ask those questions, but it's not mandatory. So, and you said everything like in the appearance, you are not seeing me, so it's very hard to say. So appearance, I would not say anything. His speech was normal in tone, volume. It was not kind of pressured. I would say his speech was normal. Then emotion was, I said okay, and yeah, it was disturbed, so not congruent. Then perception, patient had auditory hallucination, right? Because he was uh, he was hearing the precedent, that's why, but no visual or tactile. Thought form, in here there was no loosening of association. It's okay, like whatever you have been asking, I was like most of the time I was answering. So in this case also, no need to say loosening of association. Loosening of association means that you will not understand anything what the patient is saying, so just total bullshit. So
Yeah.
in this case, even you can say linear, that should be fine.
Mm. Yeah.
And then thought content, in the delusion, yes, this patient had a delusion of grandiosity, and
Yeah.
other delusion was absent. Then insight and judgment was impaired, cognition was intact, and you said about 3R, that was good. So patient is high risk. You were able to maintain a good rapport, and this history was unreliable, so collateral history will be needed. So very good, Dr. Lin. Um, it's really nice.
Yeah.
Are you preparing for your exam, or have you got any exam date?
Yeah, I now it's postponed. I plan to join exam on the June, but it
Yeah.
has been delayed. So yeah,
Yeah,
so
I understand. It's a like kind of difficult situation. There are many candidates of us who are stuck in the MCQ even. Like they know that they would pass the MCQ.
yeah,
They're not getting enough date. And some of our clinical, they have been preparing for a long time and they are very, very good, but still they are unable to appear at the exam. So
yeah,
it's a kind of global situation. And yeah, keep on going. You have been doing good.
yeah. Really appreciate your feedback. Really appreciate for
No
that.
worries. Okay. Thank you.
No, no worries. Thank you.
All right, guys. So this is how we should do the role play with our study partners. So I have shown you like this is the way. Now you should start doing the role play with your partners. That's the way to pass the exam. With lots of role play, you will feel confident, your voice will show the confidence, and your station will be very, very calm, and it will look like, yeah, this patient or this examinee can pass the exam. So it happens with a lot of role play. No one becomes pro in 1 month, 2 month, even 3 4 months. You will start becoming a pro like after 5 6 months. So try to do that, and at one time you will feel the difference. And we will be here always to help you with your progress, and we can catch you where you need some improvement, and then you will feel that, well, if I improve this part, then it will be easier for me. And lastly, we will finish today, but we just there were some other MSc video. There was a nurse with messy hair. She was crying all the time, tried to commit suicide because a patient died because of her mistake, and like she also had some auditory hallucination. So patient had delusion of guilt, auditory hallucination, suicidal ideation. Another case was like same schizophreniform. In here, it was like the finding was patient want to meet with the UK president because there is some war coming on and some change in the world, and he has a big role to play. Just like I said, it was kind of same. Okay, so that was the same MSc. Nothing much to add in our today's session, but I would just talk with you about our course a little bit, like about 5 minutes time, if you guys are happy. So first of all, let us show you that what this course is all about and how we can help you with your preparation. I know that most of you has already gone through our course details and our videos and everything, but still I would just show you our course and how it's really, really resourceful and it's very cost effective. Let me show you. Just give me a second. First Aid AMC offers you the best available software for your preparation. You will get lifetime access to hundreds of lecture notes divided into clusters and topics. As you can see here, every notes that you need to prepare for your exam are here organized in a very specific way. You can get all the lectures according to your clusters, topics and subjects in your software. You can open any of these notes and you can read it while you are on the train, on your bus, on your car, everywhere you can get access to the software. We have also organized all the questions according to the months. So if you want to do role play with your partner, you can open one of our role play topics and then you can start preparing those topics. As you can see here, I just opened this one and you will get all the questions related to vomiting cluster one by one, and that's organized according to the month. And the lastly, which is the best, that's our recording. Just after the class, immediately you will get the recordings of each and every class in our software uploaded, and you can easily listen to the class if you miss it somehow. In a word, First Aid AMC software gives you the lifetime access to your AMC clinical preparation. All right. So thank you so much for listening. I hope that it clears some of your confusion or anything about this course. And if there is any questions about the course and everything, you can easily ask it here. And the good news is that there are a couple of very important sessions are coming out for you guys. One, I was going to take a class, not a class, I'm going to offer someone from you just a free mock test. It will be a 16 station mock test and it will be totally free and everyone will be able to listen that how the online exam can happen. And I think before your exam it will be the best preparation and everyone will understand that, well, this is how I should prepare. We still don't know too much about how AMC is going to take the exam, but most of it we know. So we'll make a question about 16 station and we will take one candidate. We'll give him or her that access to do that exam with us. And you guys can also listen to that. That will be a very important for all of you. So we will know that how online exam can happen and how we should prepare about that. And the next thing that we're going to take a 2 weeks free sessions for you. So in the 2 weeks free session, you will get to know about our course much more better. Like, yeah, I know that I'm very good at psychiatry. And if I just take you the psychiatry class, and obviously everyone will like the psychiatry. So you should not just rely on the single class. You should also see how I take other classes. So I will take the pediatrics class, I will take medicine class. And after taking that class, if you guys feel that, well, this is a safe course and I feel like, well, this course can help me with my preparation, then only come to us, email us, and we'll be happy to take you in. Okay. So the free 2 week session is gonna start from 31st of October. We'll give you the schedule tonight or tomorrow, and then you can do the 2 week session. This 2 week session is for those who are still confused that if you guys want to join or not. Okay. And I think that would be a very good session for all of you. Okay. Is there any other questions you guys have? So Dr. Nargis Akhtar, about the concrete thinking, it means that patient doesn't understand the actual meaning of a sentence. Like if I say, what would you do if an if an insect is here. Now, patient with schizophrenia will feel like, well, the insect is just near him. But normally how you would answer, you would say, well, if there was an insect, I would run or I will try to kill it. But schizophrenia patient will have a concrete thinking. They will say, oh, where is the insect? Oh my God. So they will just look like they will have this sort of thinking. The pattern of thinking is kind of weird in them. Okay. The detailed plan will be on the Facebook. So all the plan, all the recordings will be in the Facebook for now. Up to, when the 2 weeks free session is gone, then everything will be software based, and also like the class schedule and everything will be in a course group. We will create it for you. The course is 5 months duration, and the fee is, as we written in here, it was 799 Australian dollar, and you can pay in 2 installations. If you guys have any questions or anything, we will be there in our free sessions also. So feel free to ask us, and also feel free to ask any queries in our email. All right, our team is working like around the clock to help you guys. So all our team members are working day and night. So if you have any questions, just ask in the email. Someone of the team will answer you. Now, if you have more than 10 years gap, Dr. Sam, I would say like better to go into the GP pathway for you. Now, in this 10 years gap, do you mean that you haven't done any work, like no medical related work? Yes. So it's a kind of difficult, I would say, but it's not impossible. What they would ask you after passing AMC, MCQ and clinical, you should pass the clinical, obviously, because that will increase your chance of getting a job. So in that case, I would recommend go back to your country, do a 6 month experience in the country so that you have some recency of your practice. Okay, then sometimes that can help. Are you in Australia? Yeah. So if you're in Australia, then it becomes easier. Otherwise, it would be really difficult, I would say. But yeah, if you are in Australia, then there is still hope. So pass your MCQ clinical, do the English test, and then I think it's a good idea. Two options. One, you can do some observership for if you know any GP in your area. So do some observership and see that if if you pass MCQ and the English, is there any GP clinic are happy to take you in? They usually ask you to appear the PESCI exam after that, and if you pass the PESCI exam, then you will be a GP. Otherwise, if they don't want, then the other pathway is just going back to the country to some recency of your practice, and then again apply. But it's not impossible. I have seen a lot of candidates getting job in Australia even in that gap. So there is hope still. Also try to do some diploma in pediatrics. Try to do some online diplomas that will give your CV a good looking thing that is still like in these 10 years you are not just totally sitting down, you have done something. I think we can also arrange a session for you to discuss about all these job situations. Then I think you will know the job situations and everything, and then you can also prepare for that. We help our candidates after passing their clinical exam. We help them with this sort of issues. So we help them to see how to write a CV, how to go for a job interview. So we help them. So obviously you guys will get some help from us. I would say like any diploma, doctor. Like do the best thing to do is either psychiatry. You can do some pediatrics. These are good. Like psychiatry is very good in Australian job sector. We don't have any PE trial class. We take the PE class in our course, and it's okay because now that is the COVID situation is still going on, and there is still all the borders are closed in Australia. So we don't take offline physical examination for this year, but the next year we will if everything is okay, we'll open our office again, and then you guys will be come to our office and do some face-to-face physical examination, but right now it will be online. So it's okay, like you will see, like you can talk with our previous candidates. Online physical examination can happen, and trust me, I try my best to give the best idea about physical examination, and you will love it. Okay, thank you so much, guys. It was nice to discuss cages with you, and also someone of you like came up and did some role play with me. It was really great. Thank you so much for your cooperations and everything. We hope to see you again soon, and the schedule will be up in the Facebook group. Now, if anyone of yours Facebook you are not permitted to the Facebook group, or if your approval is pending, the only cause is that maybe your profile picture is suspicious, that means no profile picture, or maybe you don't have any personal information. We are really particular in that. So if like I understand someone of you might have some problem with showing your picture, but in that case you have to send us your documentation, just some part of your documentation showing that you are the right person, you are not any fake person or any spy from any other course. So that's just the thing we want. So please make sure you can send us your passport name blurring everything, or your driving license just name blurring everything, and your AMC status, that if you have got any message from AMC, you are a part of ECFMG. So just something that we are sure that you are a candidate who is looking for help. We haven't uploaded schedule yet, so it will be tonight or tomorrow. No PE session on free class. I'm sorry. Yeah, usually the PE sessions will be usually we take it in the second month of our class. So usually we usually take cardiology and pediatrics class on the free sessions. No PE sessions. Sorry. Yes, Dr. Cynthia, we don't create your CV, but we help you to show you that, well, these are the wrong thing that you have done. You can improve your CV by doing that. So we help you with those sort of things after you pass the exam. Thank you all. Have a good night. Bye.